Hello and welcome everyone. I know we still have some people popping in, but I can start my background info. My name is Matt Shepard. I'll be your moderator for today's Team Gleason Center for Medicare Advocacy webinar, an overview of Medicare home health coverage. This webinar is brought to you as part of the joint Team Gleason Center for Medicare Advocacy Medicare and Home Health Initiative to help people living with ALS understand Medicare, including the home health benefit, and to maximize access to coverage and care. A little bit about our two organizations. The Center for Medicare Advocacy, as some of our audience already know, is a nonpartisan, nonprofit organization, which, since its founding in 1986, has worked to obtain fair access to Medicare and quality health care for older people and people with disabilities through education, training, analytical research, advocacy, and legal assistance. The center is staffed by attorneys, advocates, nurses, and technical experts, all working for systemic change based on our daily experiences with the problems of real Medicare beneficiaries. Team Gleason's mission is to help provide individuals with neuromuscular diseases or injuries with leading-edge technology, equipment, and services to create a global conversation about ALS, to ultimately find solutions and end the disease, and raise public awareness toward ALS by providing and documenting extraordinary life adventures for individuals with muscular diseases or injuries. The Medicare and Home Health Initiative includes last week's webinar giving an overview of Medicare for people living with ALS, this week's home health webinar, and a third webinar on May 9th, which will examine some case studies in detail. Thanks, by the way, to all of you who attended last week's webinar, and apologies if all this background sounds a little bit familiar. But continuing that background, the Home Health Initiative also includes a dedicated email portal for those living with ALS to ask questions and share home health access stories. You can share yours at homehealth@medicareadvocacy.org. In addition, Center attorneys will be hosting several virtual town hall calls every second Wednesday at 3 o'clock through June, July, and August for people living with ALS, where we can discuss the answers and stories and take live questions. And once again, we thank Team Gleason for their support of this important initiative. Today's home health webinar will be presented by Center Executive Director Judith Stein and Associate Director Kathleen Holt. Before I let them start, however, I need to do some more housekeeping. If you can hear me, you've used the information in the email you received after registering to successfully log into our webinar, and you've dialed in by phone, or you've got good quality working speakers on your computer, either of which is great. If you use the telephone call-in, we'll be able to hear you when we open up for questions. Otherwise, please be absolutely certain your computer has a good quality microphone. If you aren't, it's never too late to dial in using the instructions provided on the confirmation email you got, or under the audio tab on the control panel that should be at the right of your screen. If, as has happened on occasion, you have dialed into the audio without logging into the online portion, you'll be able to hear us, but you won't actually see that control panel or the presentation. You do need to log in or we won't be able to interact. So let's discuss the control panel that I've mentioned a couple times. There are some key features for our purposes today. Please note the buttons on the tab at the left of the panel. There is a little orange arrow that lets you hide the panel so it's not in your way. There's a little square that'll let you watch the presentation in full screen view. And then finally, there's a little picture of a hand. That's used to indicate that you have a question. For the bulk of the presentation, we're going to keep our attendees muted, but when we open it up for questions at the end, you can use that little icon to indicate you want to speak, and I will unmute you. And don't worry, if we don't get to your questions live, or you decide you're shy, or we have some sort of connectivity issue when we try to open it up that doesn't allow you to ask it out loud, you can type questions into the questions section of the control panel. Or you can email them to us at homehealth@medicareadvocacy.org. Please do note as well that this presentation is being recorded for future viewing, so if you don't want to be heard or have your inquiry read live, do use that email address, homehealth@medicareadvocacy.org. Finally, while everyone should have received a copy of today's slides and Medicare's home health booklet at the email address they used to register, if for some reason those didn't make it to you, you can download them right now, live from the handouts section of the control panel. Thank you all again for attending today, and I will now hand things over to Associate Director Kathy Holt. Kathy?
Thank you, Matt, and good afternoon, everyone. Today, we're going to look at home health care as regards to Medicare. So bear with us, everyone, because we know that there's a lot of variation in how much information people have received about Medicare home health. So we're going to start back at the beginning, go through all the basics, and hopefully that will help people who are unfamiliar with the Medicare benefit, and will also help refresh the information for people who have been using it for some time. Judy will discuss in parts 1 and 2 coverage criteria and services and the JIMMO settlement case. Then I'll speak about current obstacles to getting care and advocacy tools and practical tips that you can use to maximize your efforts in getting home health care. And finally, as Matt mentioned, then we'll discuss questions and any other issues that you have regarding home health care. So I'll pass it off to Judy.
Thank you, Kathy, and it's lovely to be with everyone this afternoon. I'm going, as Kathy said, to talk, starting with the basics, sort of Medicare Home Health 101, so that as much as possible, you will all have basic knowledge regarding the coverage criteria and the services that can be covered under the law if you meet the coverage criteria. Here's a graphic which gives you a good, we think, overview of the basic coverage criteria that must be met in order to be able to get the services covered by Medicare that you need to stay at home with quality of life and health care. I also want to point out that at the bottom of many slides, we're going to have reference information. These are citations or information that you can be sure to use with your home health agency or anyone who's telling you that what we're telling you isn't so, because it's all based on the law, on federal regulations, which is CFR, as you see here, or on the Medicare policy manual, which is often what the Medicare agency, home health agency you're working with relies on, and also on the Medicare home care booklet, which Kathy will refer to later. So here you have, again, the basic coverage criteria. First, it's always true that you need to be under the care of a physician, and a doctor has to have ordered care in order for it to be covered under Medicare. For home care in particular, the doctor needs to have written up what's known as a plan of care and certify that the care that you are to receive is medically necessary and reasonable, and that you are what's known as homebound under the law. He or she, the doctor, needs to sign off on this and say that either the doctor or another qualified medical personnel, such as an advanced practice registered nurse, had a face-to-face meeting with you and determined that the care that has been ordered in this plan of care is necessary, it's reasonable, and that you are homebound. So what does homebound mean? That's a legal definition and is included in the Medicare regulations, the statute, that is the Medicare Act, and in the Medicare policy manual. It does not mean that you're bedbound or that you can never leave home. And I'll be discussing each one of these green segments in detail in a moment. But it is a legal definition, and it means that generally it takes a taxing effort for you to leave home. It requires assistance of another person or of a device such as a wheelchair or walker, or that there's a mental or emotional reason that it's contraindicated that you leave home, even though you might be physically able to do so. And finally, as I say, the care must be reasonable, necessary, and there must be a skilled service that's ordered. And that requirement will be met if you need nursing or physical therapy or speech language pathology services. So these are the three basic criteria that must be met to start care, to begin Medicare coverage. And we give you this as one of the slides you may want to print out as a reference going forward. Now, the first criteria that I mentioned is under the care of a physician. And this means that there is a doctor who has ordered the home care and has written and signed off on a plan of care, which includes both the specific medical or therapy treatments that he or she is ordering, the nurse, the speech language pathology, or the physical therapy, or a combination thereof, and also the frequency that the doctor thinks you need those services and is ordering them to happen. And this plan of care must be reviewed and recertified every 60 days. And I'm sure Kathy will talk about this in a bit, but we do highly recommend that you ask for and get a copy of this written plan of care and look at it. And if it doesn't seem to be what it should be, to contact the doctor and talk about what you think should be in it that might not be. Again, as I mentioned, the doctor has to have conducted and sign off on a face-to-face meeting. This can happen with someone other than the attending physician. Could be someone in the hospital if you were in the hospital, or a registered nurse, an advanced practice nurse. But the doctor who is signing off on the plan of care must also sign that there was such a face-to-face meeting. And again, here you have the citations from the federal regulations in which I'm relying upon for these statements. Now, as I said, the second bullet that needed to be met in order to start care is that you have to be what's known as confined to home under the law, and often referred to as homebound. This notion is that, intent of this notion is to make sure that people who get care at home really couldn't get it elsewhere, because we're putting a lot of resources into getting home care provided under the Medicare law. And so that's the intent. The individual must require assistance of another person or a supportive device, and that means could be a cane, or it could be a walker, or it could be a wheelchair to leave home. Or, as I indicated earlier, a person might be physically fit, but psychologically or mentally or cognitively impaired in some way that it's contraindicated for him or her to leave home. And regardless of whether it's a physical or emotional or mental limitation, there has to be a normal inability to leave home. So generally that it's difficult to leave home. You normally don't leave home alone, and it takes a considerable or taxing effort to do so. And here you have the citations for the first time for the Medicare Benefit Policy Manual. The Home Health chapter of the Medicare Benefit Policy Manual is Chapter 7. And this is often the document that home health agencies rely upon. So whenever you see something in these slides, or we tell you something that may sound different when you talk to a home health agency, this is one of the places you really would want to show them. Well, it's in the Home Health Policy Manual, and we know you often look at that home health agency. So in order to meet the homebound requirement, you don't need to be bedbound for sure. And it's not true that you can never leave home. And sometimes you may hear that from a home health agency or from someone who doesn't understand the law. You can leave home for healthcare. So as you see here, medical appointments or therapy that's not available at home can't be provided at home. If you attend an adult daycare center for therapeutic or psychosocial or medical treatment, and very often it is widely understood that adult day centers are a place where people get psychosocial assistance just by being present, that's okay. Infrequent absences or absences for short duration are also allowed and will not keep you from meeting the legal definition of homebound. In particular, religious services are deemed to be infrequent and short, even when they might be a long service, or you might go on more than one occasion a week. The law says that leaving home to attend religious services is okay. And in addition, occasional trips to the barber, a beauty salon, a walk around the block, or a family occasion, these things should not keep you from being homebound. So long as they are infrequent, the absences are a relative short duration. Now, in order to see if you qualify, you might want to ask some of the following questions. Again, is there a walker, wheelchair, or other device needed in order to have someone leave home? On the other hand, does the person have cognitive impairment or an emotional reason why he or she shouldn't leave home or isn't? Is special transportation arrangement necessary in order to leave the home? Is a special equipment necessary? So, for example, a Hoyer lift to get out of bed or get into the wheelchair, a person's wheelchair. Can the person transfer themselves, dress themselves? Look for issues like difficulty with a grip, upper body paralysis, these other things that we list here that would certainly indicate that a person needs assistance in order to leave home, or it's really not appropriate for them to leave home by themselves. Is there evidence we just mentioned of a taxing effort? And that can be, for example, even if a person drives. We've had situations where, yes, the person is driving a specially made vehicle so that it's accommodating his or her disability, but to get into that van takes, or often it's a van because a person needs a wheelchair, but if it's not, getting into that specially accommodated vehicle takes a taxing effort and maybe some special equipment. It should not automatically mean the person isn't homebound. In general, like in everything we're going to tell you, look at the specific individual's overall condition and experience rather than some rule that people generally in these kinds of situations aren't homebound, and also look in general to the situation of the individual rather than some isolated period. So, for example, we've seen inappropriate homebound denials for someone who might have been seen walking to a mailbox when that may actually have been ordered as something that he or she should do. We've seen denials when someone maybe has gotten on a special vacation trip, and we know that Team Gleason often tries to have things like that happen. That doesn't mean and shouldn't that the person isn't homebound. And again, here's a section from the Medicare Home Health Policy Manual that speaks to what I'm telling you here. So if the person has the plan of care, the doctor has signed off on it, the face-to-face meeting has occurred, and they are homebound under the legal definition, then what is the next step? The next step is, does the person need skilled services? And a skilled service to begin to start coverage is defined as intermittent nursing or physical therapy or speech language pathology services. One of those three services, just one of them, is necessary to start care. And if care is started, that is, coverage is started, and then none of those three services, nursing, physical therapy, or speech language pathology, is needed anymore, but occupational therapy continues in place and is needed, then that is a skilled service that is recognized to continue coverage. So what do we mean by skilled under the law? So the nursing must be skilled and the therapy must be skilled. And that means that a qualified person, a professional, is needed for the care to be safe and effective. So sometimes you'll hear that, well, a family member could do this, or the person could be taught. The question is, will that service be safe and effective if it's not provided or even supervised by a skilled person, a skilled nurse or a therapist? That is key to the definition of whether it requires the skilled personnel. And in many instances, that can be to provide it or to supervise the care to make sure that it's safe and effective. Now, in the federal regulations, that's the CFR, Code of Federal Regulations, there is a list of defined skilled services, and I'm going to talk about them in a moment. And if the service that's needed is in that list, it should be automatically qualified as a skilled service. And note that there's no duration of time limit. Medicare home care coverage is available so long as the skilled care is required. So if one of these services continues to be necessary, then Medicare coverage can continue under the law. So now let's look at each of those individual skilled services separately. The first being skilled nursing, which must meet the definition of intermittent to begin coverage. And what does intermittent nursing mean? So in this instance, what we're talking about is how often is that skilled nurse necessary, not whether the nurse is providing a skilled service. And the question is it provided fewer than 7 days a week, but on a recurring basis, or as much as 7 days a week, but less than 8 hours a day, and likely the daily need is going to be required only for up to 21 days. Although even that, under the law, can be extended in exceptional circumstances. So the notion here is that the nursing has to be recurring, and it has to be provided at least fewer than once a week, but recurring, or daily, but less than 8 hours a day. And usually it's likely to end within 21 days. But the doctor can certify if the daily skilled nursing doesn't end after 21 days as expected, that he or she still expects that after 3 more weeks, the daily nursing will end. And in that case, the daily nursing should be legally allowed and covered under the law. And again, it's based on what the doctor expects at the beginning of the certification and recertification that will happen at the end of the 21-day period. Will that daily need end? There is an exception, another exception, and that is that the law recognizes that daily insulin injections may be necessary and may be required to be provided by a nurse, particularly in most states, and that will qualify as a Medicare covered service if the individual cannot self-inject. And again, here you have the citations from the Medicare Home Health Policy Manual. Now, we want to know what is a skilled service, a skilled nursing service. And here we look to the federal regulations, which specifically define skilled nursing services, and that includes the following: overall management and evaluation of that care plan that we talked about that the doctor has ordered, and a nurse can be required to look at it, make sure it's happening, and if anything needs to be changed. Observation and assessment of a changing condition by a nurse, patient education services provided by a nurse, and then there's a list of specific other skilled nursing services that are recognized under the law, and I'll describe each of those as well. So first, overall management of a care plan. This is when the patient requires a nurse to manage a combination of otherwise non-skilled services. So the condition of the individual could be so complex that even though the nurse doesn't need to do the actual service, there's so much going on that we need to make sure that it's happening appropriately and that doesn't need to be tweaked or fine-tuned over time. And the nurse can come in, evaluate the situation in the person's home, make sure that that plan of care is being attended to properly, and get back in touch with the doctor if it needs to be changed. That is called management and evaluation of a care plan and is a recognized nursing service under the Medicare law. And here, in particular, it's the Medicare the federal regulations which have this list of skilled services, which include the management and evaluation of care plan. And in order for that to be paid under the law, it must include a brief narrative by the doctor. Observation and assessment of the patient's changing condition is another skilled service under the federal regulation. And in this instance, it's important to note that even if a change hasn't occurred from the first, say the nurse came on 2 weeks ago and returns today to see and check on the patient and finds that everything is pretty much as it was 2 weeks ago. That's good news. Nothing's gotten worse. May note some improvement, but if the nurse still feels that there's likely to be a change given the person's overlying condition, and we know with ALS that can certainly be the case, then that still is a skilled service, because the important thing is to get a nurse in to check on things and make sure that the situation and the care is as it should be. Even if there isn't a change yet, if there's a likelihood of future complication or a change, then the skilled observation and assessment can continue. And if you're told it can only go on for 3 weeks, here too, that depends on the situation of each individual, and whether the nurse thinks it's still possible that things will change and he or she better come back. This is a colleague who always refers to observation and assessment as the gold standard of nursing. And it's important to note and remember that even though people with AS and their family members become quite as adept at many of the services and care that they need, nonetheless, that doesn't mean that observation by a skilled nurse isn't needed and appropriate. And it can continue so long as it remains a reasonable potential for change or complications. And that's what I wanted you to see here, and that this is in the Home Health Policy Manual. These are the kind of general statements you may hear contrary by a home health agency, that it just can't go on any longer. And we want you to have the tools to respond to that. Now, another service that a nurse might provide is patient education services, both to the patient and perhaps to any family member or home health aide that is in the home. And it is definitely recognized as a skilled service. This can be so important, whether the nurse is providing the care, supervising, or teaching, that it be done right, and so that things don't go awry. And it's apparent, we see here, after a reasonable period of time, that the patient or caregiver could not or wouldn't be trained, then maybe it could end. But until such time, it's inappropriate, the law says, to assign a specific time frame for these services, because it's going to differ from patient to patient, circumstance to circumstance. So each individual's circumstance must be taken into account to determine how long these patient education services are going to be recognized as reasonable, necessary, and skilled. And we note there that it could become quite complex, and the person might forget, or the caregiver may forget. That doesn't mean that the teaching is unnecessary, and rather perhaps a new technique might be necessary, and the services might indeed be necessary to continue. Now, as I indicated, there's also a list of what we call per se skilled services in the federal regulations. And by per se, I mean that these should be recognized as skilled services to start and or continue care and to gain Medicare coverage under the federal regulations. And these skilled services that are included in the law are intravenous or intramuscular injections, intravenous or enteral feedings, insertion and sterile irrigation of a suprapubic catheter, application of dressings involving prescription medications and aseptic techniques, treatment of extensive decubitus ulcers and other widespread skin disorders, and aspiration services. And this is so important to note that even here we sometimes see a patient getting some of these services and being told that it's not a skilled service to allow Medicare coverage, and it's simply not true. As an important advocacy tip, remember and keep holy and maybe print out this section from the Medicare Home Health Policy Manual. A patient's overall medical condition must be taken into account without regard to whether the illness or injury is acute, chronic, terminal, or expected to last over a long period of time, when deciding whether the skilled services I just described are needed and should be covered under Medicare. And the patient's diagnosis should never be the sole factor in deciding, and certainly not in denying Medicare coverage. And again, we want you to know that even if the condition is stable for a period of time, that's not a reason for denial. So reason we bring this to your attention so definitively is that all of these are some of the things you may hear contrary from home health agencies, and we want you to have the tools to challenge them. Another important advocacy tip and citation here from the Code of Federal Regulations is that the restoration potential is never to be the deciding factor in deciding whether Medicare coverage is available. Indeed, and this is from the federal regulations, and I quote, even if full recovery is not possible, a patient may still need skilled services to prevent further deterioration or to preserve current capabilities. And we know this is so important for people living with ALS. Regrettably, you may not improve over time, but we want to get all the skilled services in place to do all we can to make sure that's as likely as possible, and to prevent further deterioration or slow decline whenever possible. And those are skilled services. Improvement is not required for a service to be skilled and covered under the Medicare law. So that's about nursing, and what I just told you is equally true for skilled therapy. But there are also some sections in the law that specifically refer to the therapy. So I want to talk to you about that now. So the skilled therapy recognized under the Medicare law for home care coverage is physical therapy, speech language pathology services, and occupational therapy. And as I indicated, occupational therapy is sufficient to continue care. The first two therapies are necessary if there's no nursing to start Medicare covered care. Now, the skilled therapy must relate directly and specifically to a treatment regimen. That's just simply going to be the case likely, but make sure that the doctor has written his order that the physical therapy, for instance, is necessary to maintain lower lim flexibility that is becoming rigid or inappropriate, unhelpful as a result of the person's ALS, and it's designed to treat the person's underlying illness or injury. Or indeed, should you have some other thing occur, so a person might fall and end up with a strain or a break, then the service could be tied to that and not necessarily only to the underlying ALS diagnosis. And the service, as always, as a general rule under Medicare, must be reasonable and necessary. There must be an expectation that the patient's condition will improve materially in a reasonable period of time, or, so I'm not emphasizing that, but what I want to emphasize here is that the skills of the therapist are necessary to perform a safe and effective maintenance program. So if in fact the strained knee can get better from physical therapy, or the person's going to be able to utilize a spoon more effectively from the services of an occupational therapist, or swallow more effectively from the services of speech language pathologists, we certainly want to have that noted and documented in the record, because it will just make things easier. But if the therapy is needed to make sure that there's a safe and effective program to maintain function or slow decline, it is equally covered under the Medicare law. And so here we have the citations, the proof that that's true. Under the federal regulations, Code of Federal Regulations, again CFR, maintenance therapy is a covered service when its specialized knowledge of a qualified therapist is required to design and establish that maintenance program. And we go on to have this section from the Medicare Benefit Policy Manual, where services that are required to maintain the patient's current function or to prevent or slow further deterioration are of such complexity or sophistication that the skills of the therapist are required to perform them safe and effectively. The maintenance therapy is covered. And I want to really emphasize how important this is. Don't buy into that somebody who's not a qualified therapist could perform these services if it's simply not true. We know of circumstances where well-intentioned family members, family caregivers, even physicians have inadvertently done harm, strained a limb when they tried to do that which a therapist really needed to do. So we need to recognize the skills of each individual type of provider and make sure that the right provider is providing or supervising the service. Now, occupational therapy, as I've indicated, can be the only service when it is originally ordered with the nurse, physical therapy, and speech language pathology, and then if the other services are discontinued, and the OT continues, the occupational therapy continues, it will allow the rest of the home care package to continue with Medicare coverage as well. And one of the things that we've been seeing in some records that Kathy in particular and other colleagues have been reviewing is this notion, bizarrely, that OT and PT are duplicative services. That's not true. The law recognizes the possibility of physical therapy, occupational therapy, and speech language pathology, as well as nursing, being necessary and reasonable under a care plan and continuing so long as they are needed by the patient. In order to determine that, always an individualized assessment regarding eligibility for coverage is required. Do not accept that this simply isn't allowed for people with ALS or in general for people who have a certain amount of mobility or a certain amount of certain kinds of conditions, because an individualized assessment is required under the law. What do you need and what is your doctor ordered? The restoration potential of an individual is not to be the deciding factor. And Medicare should never be denied because the patient has a chronic condition or needs services to maintain his or her condition. The question is whether the skilled service, in this case the therapy, is required to preserve current capabilities or prevent further deterioration. If there's no skilled therapist in place, what is the likely consequence? That's a question to ask. Home care can continue. It says this in the Medicare Policy Manual as well as the federal regulations, so long as the qualifying criteria are met. That's why it's so important to make sure that these skilled services stay in place if they're needed. And if the home health agency says that Medicare won't cover, they need to give you a notice, and they must submit a claim to Medicare if the beneficiary so requests. And however, once the claim is submitted, you will get a formal decision which you can appeal. But the home health agency then can hold the individual is responsible for payment until and unless Medicare coverage is granted. So if there are skilled services, then what? Well, dependent upon a skilled service being in place, that nursing, therapy, speech language, physical therapy, speech language pathology, or occupational therapy to continue care, then there can be what are known as dependent services also provided and covered under Medicare. And those include home health aides, medical social services, and some medical supplies. If an individual receives the skilled nursing, the therapy, or the therapy, then those dependent services are coverable. And so importantly, one of these mainly important dependent services is home health aides. And I'm going to talk about those next in some detail. But note that the amount of the skilled service or the type of skilled service does not determine the amount or type of dependent service. So it doesn't matter whether the skilled service that's qualifying you for coverage is nursing or therapy, you still are entitled to eligible for the same array of dependent services. And those, as I said, are home health aides, medical social services, and some medical supplies related to the illness or person's illness or injury. For example, a catheter or ostomy supplies, a home health agency should be bringing those in and helping with the provision of services related to those supplies. This does not include durable medical equipment or prosthetic or orthotics that would be covered separately under Medicare Part B. So let's look at home health aides, which are so important. Home health aides combined with nursing under the law can be provided and covered up to 28 hours per week, any number of days per week, so long as they are provided less than 8 hours every day, and with a particular documentation, if the doctor shows that this is necessary, those home health aides in combination with nursing could be provided under the law up to 35 hours per week. And here I have for you the law, the United States Code, which is where the Medicare Act itself can be found. And that little squiggle means section. So it's section 1395 of the law that says what I just told you. Now, regrettably, we know that this is far less than the people are able to receive as a practical matter now. And that's one of the things that we're trying to change. Now, home health aides are defined as providing personal hands-on care. This is generally not homemaker services, and certainly not homemaker services alone. That won't be covered under Medicare. But if a skilled service is in place and the home health aide is providing personal hands-on care, then if incident to that, they clean up a bit, that will be okay. The Medicare Act specifically establishes home health aides, which sometimes can be seen as a custodial service as opposed to the skilled care we just described, as a covered service under the Medicare benefit. And here's both the law, the United States Code, and the federal regulation sections. Again, that's what that little squiggle means, to help you have the proof that what we're telling you is true. Now, a patient is eligible to have the cost of reasonable and necessary services reimbursed by Medicare, I would say covered by Medicare, without regard to whether there is someone available to furnish the services. And this is very important because we often hear home health agencies say that the caregiver could provide these services and we're not going to provide them because there's someone in the house. In fact, the home health manual specifically says that it's to be presumed that there is no willing or able caregiver to provide the services. And even if there is, it doesn't mean that the patient, the individual, can't get home health aides to come in and provide those care and have them covered under Medicare. This is very important. By the same token, the home health agency shouldn't be requiring you to have someone in the home as a precondition of them providing the services. And so this notion that there has to be a willing caregiver or that you can be denied if there isn't one is not allowed under the law. And here's the benefit policy manual section, which says exactly that. Now, one of the important things for folks and those who care for and about them with ALS really need to know about is the JIMMO case, which the Center for Medicare Advocacy was lead counsel and settled in 2013, although the settlement was only finally resolved in 2017. And we want you to know that this actively and absolutely applies to people with ALS, and it specifically applies to Medicare coverage for home health care. Now, the case was a lawsuit brought in 2011, and you see here some of the entities and were plaintiffs, it's called, in this lawsuit, and there were also 5 individuals. But what I want you to know is it's not limited, and I'm seeing some of these questions and incorrect answers given on our Facebook and Twitter feeds. It is absolutely applicable to people with ALS, and in fact, JIMMO is not limited to people with only certain diagnoses. Now, what does JIMMO mean? JIMMO was brought on behalf, JIMMO is the last name of a lady who lived and has since passed away in Vermont, who in fact was denied Medicare home care services, despite the fact that she was very clearly homebound. She was legally blind and had an one leg amputation, and she had very brittle diabetes. It means, and as a consequence of the settlement, it meets that Medicare level of care criteria. That is, if the person is homebound and has the plan of care assigned and needs a skilled service, as I described earlier, that if that's needed to maintain an individual's condition or slow decline, that Medicare coverage should be just as available as it would be for somebody whose underlying condition is going to improve. And that's what's so important. The settlement required CMS, and CMS is the Centers for Medicare and Medicaid Services, to revise its policy manual, among many other things, to clarify that Medicare coverage does not turn on the presence or absence of the potential for improvement, but rather on the need for skilled care. And that includes nursing and therapy. So the services can be covered when that professional is needed to ensure the services are safe and effective. Not to ensure that you're going to improve, but that the services provided are safe and effective, including and equally to maintain, prevent, or slow decline. And again, here's the section from the Medicare Benefit Policy Manual regarding home health. And the JIMMO settlement specifically includes home health care. Again, here's some more information for you that you can cite from the Benefit Policy Manual. And the policy manual, again, is very often what home health agencies rely on. It's kind of like their Bible to look to see what Medicare says, but they may hear otherwise from those who implement the Medicare law. So now you've got the sections you want them to look at. Maintenance nursing services are Medicare coverable to maintain the person's condition, and the decision should turn on whether that skilled nursing is needed, not on whether the person is expected to improve. By the same token, maintenance therapy is a covered skilled service. And for years, the denials based on the person that the fact that the person needs, quote, maintenance therapy only, we were seeing them all the time. And you should not see them now. If you do, it's not legal. Those services, if required to maintain function or slow decline, to be provided by a qualified therapist, are skilled services that should be covered under the Medicare law. And again, here is the Medicare Home Health Policy Manual to refer to. So the question to ask with regard to home care coverage and the application of JIMMO is so important here. Is a skilled professional needed to ensure the nursing or therapy is safe and effective? If the answer is yes, then Medicare may well be available. Is a qualified nurse or therapist needed to provide or supervise the care? And again, if the answer is yes, then Medicare coverage should be available, regardless of whether the skilled care is needed to improve or maintain or slow deterioration of the individual's condition, or if the condition is chronic or stable or has plateaued. And you know, we're still seeing that language that the person has plateaued. And sometimes that may be true. An individual's therapy may be such that there's no change after this week, after a couple of weeks. That does not mean that the services don't need to continue to make sure there isn't decline or perhaps even some bit of improvement. That could still happen. JIMMO and prior law, and that's why we won the JIMMO lawsuit, require an assessment of each individual's situation. We don't want you to be told that people with ALS can't get this and can only get that. That's not legally it's not only not true and not fair, it's not legally allowed. Medicare should not use what's known as a rule of thumb to deny coverage or make decisions. Rather, it's required that an individual's determination is made regarding whether skilled care is necessary, and that determination must be based solely upon the beneficiary's unique condition and individual needs, without regard, and this is so important, with what each individual needs, without regard to whether the illness or injury is acute, chronic, terminal, or expected to last a long time. And as Kathy will elucidate, we know you will hear otherwise. We know, unfortunately, people are hearing otherwise, that the care can't keep going on, or it's a short-term or acute care benefit, or that you have to get better. And we hope that you now have the tools to counter some of those erroneous statements. And with that, I'm going to turn it over to Kathy to talk about obstacles to getting Medicare and care.
Great. Thank you so much, Judy. So what are the current obstacles to getting care? Let's look at those. And then in the next part, we'll also look at what currently can be done about them. So obstacles to care, narrow misinterpretations of coverage laws. We find this quite often. The home health agencies are often pressured by payments and audits. They narrowly interpret what the coverage laws are. Sometimes it's for survival purposes on their part, and we're trying to work with them to help them, but also encourage them to open up their participation in Medicare in such a way that equally serves all people who qualify for the services. By Medicare contractors who demonstrably don't know the law and sometimes arbitrarily deny and teach the home health agencies improper applications of the law. And I'm being unfiltered and rather blunt about this, but I think that this is not anything that is necessarily anyone is in particular setting out to do this, but we need to look at what the reality is and what you're facing when you're going out and trying to get care. So there's a lack of understanding about the JIMMO case, and as Judy so eloquently laid it out, there really needs to be a better understanding of how the JIMMO case is to be applied. And there's oftentimes a fear of Medicare audits, again, by those Medicare contractors who are coming in and making it difficult for home health agencies to meet the Medicare criteria. So just briefly, the payments to agencies has been a problem. And from an ALS standpoint, there are case mix weights that are based on the initial assessments for care. And quite frankly, they're not strong enough. Those case mix weights are not strong enough for people living with ALS. And when I mean that, those are the payments that are made based on an ALS diagnosis. They need to be higher payments in order to properly encourage agencies to serve people with ALS. So that's something we're working on. Medicare certified home health agencies are not required to provide services to all Medicare patients, but they are required if they take private pay for an ALS patient, they must take Medicare for similar services. So if you find, for instance, that they'll say, oh, well, we can't take Medicare to care for you, but we'll take a private insurance or long-term care insurance, that is not proper. And again, Medicare payments for home health agencies are being decreased after 120 days of qualifying care. So again, it's discouraging agencies from keeping patients longer. So then there are the quality rules that home health agencies have. There are 23 quality measures in the Home Health Quality Reporting Program. So if you see that an agency has a 5-star rating, which is the highest rating, that means they are mostly achieving these improvement goals that you see laid out here. So again, this is a sampling of the 23 goals in this Home Health Quality Reporting Program. And they do oftentimes have to do with patients getting better at functioning, having less pain, having their breathing improved. So we're arguing that everyone who qualifies for home care should have measurable quality goals, and that these quality goals that only seem to focus on people who are improving are not adequate. Another obstacle to care are arbitrary discharge. So the patient still qualifies for care, but the home health agency may say something like, well, Medicare won't pay for your care anymore. So oftentimes what this is code for is we're not paid enough by Medicare to care for you. Medicare doesn't cover long-term services. Again, we don't want to have audits, so we as a home health agency are choosing to arbitrarily discharge you. Medicare doesn't cover maintenance therapy, which of course we know it does. We don't have the staff in order to meet your needs. Or if you only need custodial care, Medicare doesn't pay for that. Well, if that's true, then you don't need skilled care. But if you need skilled care, then Medicare does pay for the custodial care. Sometimes they'll say you're not homebound. Again, we're seeing this very narrowly interpreted. So in the next section, I'll address new changes that protect against arbitrary discharge. So let's now look at the tools and practical tips that we can apply that will help to open the door to home health care under Medicare for people with ALS. The first thing that we would point out is to use the Medicare Benefit Policy Manual. Again, this is relied upon by Medicare certified home health agencies, and we provided a link here. So it's about 100 pages of detail, but there's a good table of contents to reference a particular issue. If you're struggling with someone saying you're not homebound, or you might you need to document certain nursing and therapy issues for maintenance, for instance, those are all covered in the Medicare Benefit Policy Manual in extensive detail. Use the Centers for Medicare and Medicaid Services Medicare and Home Health Care booklet. So we sent this out today with the slides, and it's a booklet that is intended for beneficiaries' use. And we worked extensively with CMS through much of last year to revise this booklet and to the greatest extent possible, get it right. So we think that this is a really good advocacy tool for you if there's a question about what do you think you need in order to qualify for benefits under Medicare. So there are new conditions of participation in Medicare. And essentially what these conditions of participation are, they're for home health agencies. If they are going to accept Medicare patients, these home health agencies have to abide by the conditions of participation. It's the first major update in several decades, and the beneficiary protections are significantly expanded under the conditions of participation. The conditions of participation do afford greater protections for patients from arbitrary transfer or discharge from home health care, and I'll focus on that in a minute. There are a patient bill of rights, there are assessment requirements, there are patient preference requirements. For example, what time of day do you want to receive services? And sometimes we know that these are what we would seem to think of as aspirational goals for the home health agencies. And their staffing requirements sometimes get in the way of getting services when you want to. But there's a process in place by which you can at least give input as to when you want services. And hopefully people want services at different times of day. So it might work out for everyone. Then there's a requirement for more patient involvement in care planning. And from what we've heard from a lot of folks, there hasn't been in the past. Patients have been treated, they've received services, but they haven't been involved in the care planning. The other thing that the conditions of participation does is add caregivers and aides onto a disciplinary care team. So everybody enhances the communication that's available when you're receiving care. And remember the presumption that Judy mentioned, the presumption that there is no willing and able caregiver. So the new conditions of participation mandate that the home health agencies identify if there are caregivers who are willing and able to assist with care, and if the patient is willing and able to accept that care. And again, require coordination and integration of a care plan with all of a patient's physicians. So I just want to focus for a second on the discharge and transfer of patient rules, because we oftentimes have heard about patients who are just, their care is being cut off after a certain period of time. So note again, and there's a reference here to the regulations in case there's any question, but discharge is appropriate only when a physician and home health agency both agree. So the physician, your physician, has to agree that you have achieved all of your measurable outcomes and the goals, whether they be maintenance goals, to establish that are established in your plan of care. And again, those goals may include slowing deterioration of your condition or trying as much as possible to maintain the condition, the functioning that you have. Home health agencies are responsible to make arrangements for safe and appropriate transfer of a patient to another agency if, again, they feel that they don't have the staff in order to provide the necessary care that you have. So there's a much higher standard to not arbitrarily discharge a patient from home care under these new rules that just became effective earlier this year. So then we would also tell you to search under the Medicare.gov for JIMMO for, again, the formal CMS information about JIMMO. And then I also want to take a quick look at this Home Health Compare tool that's on Medicare.gov. I'm going to see if I can get into this website to share this with you. Okay, hopefully everybody can see this. So I'm going to go do a little tour of this website because I think it's really worthwhile. Let's take a tour. Let's put in a zip code that is the French Quarter in New Orleans. Okay, so what we can tell from this is that there are 32 results, and this tool will list the 32 results. So there are 32 home health agencies that serve this zip code in New Orleans. And what you can do at any point in time is choose 3 of these home health agencies to compare their results. And again, just to re-emphasize everything that we're talking about here, I'm going to choose 3 different agencies. So I'm going to add this to the compare list. I'm going to add this one and this one. So now I've chosen to have 3 agencies to compare. And now we're going to look at those agencies. So what we can tell from this, I'm having a little hard time with my cursor on the side here, is that these 3 home health agencies in New Orleans, one of them is a private nonprofit, one of them is a proprietary, meaning a for-profit agency, and the other one is a nonprofit religious. Now, these may not necessarily mean anything, but we typically see that proprietary agencies or for-profit agencies may have a tighter need to make money. So that may be something that you might want to look at as you're looking through to see what agencies have. Now, the thing that we can see from these 3 agencies is that they all provide the 6 disciplines of care in home health. So nursing, physical therapy, occupational therapy, speech, medical social services, and home health aides. If you were looking, for instance, for an agency that because you wanted a home health aide, you're going to want to make sure that as you look at the compare tool that I'm on here, that you see a green check in that box. If not all agencies provide all services, so that's one of the things that you can look for on this. Then there's another, that's the general information tab. Then there's another tab that talks about the quality of patient care. Now, the quality of patient care is essentially the star ratings that I was talking about. And typically Medicare says that the higher a star rating you have, the better your agency is. So for instance, Total Home Health Care only has 2 stars, rating stars. Stat has 3 and Turo has 3. So they're all rather on the lower end of the scale. And you can see what I mentioned before. So here are in this chart, you can see how often patients got better at walking or moving around, how often patients got better at getting in and out of bed. Well, if you're serving people that have ALS, you're not going to score very highly as a home health agency on these particular quality measures, which is why quality measures should really be geared toward the type of care that you're providing. But this is an issue that again we need to address, because there's not enough quality measures for people who are not improving. So I'm going to go back up here, and then let's just quickly look at this last tab because it's important. These are patient survey results. And the patients in these cases have had an opportunity to rate the home health agencies. And interestingly enough, if you remember from the last screen, Total Home Health Care had 2 stars from the quality ratings, measuring those things that people improve by. But the patients are giving them 5 stars, meaning that they were very happy with the care that they got. The patients were. So again, it's comparing the percentages, and you can see in this case that the percentages of how often the home health team gave care in a professional way, how did they communicate with patients, how do you rate the overall care from the home health agency. And again, that last agency that said that they only had 2 stars according to CMS is rated a 97% in their care that they provided. So it's a tool that I would suggest you look at. And again, the only way that you're ever really going to be able to choose a particular home health agency is if you give them a call and have conversations about what your physician's order is and what kind of care that you're looking for. Okay, Medicare is always looking for feedback. Okay. So then you want to confirm that there's strong documentation in the medical record. You want to know that skilled nursing and therapy is medically reasonable and necessary, and it's provided, that the homebound requirements are met, and the face-to-face requirements are met. Document the need for dependent services, for personal hands-on care if a home health aide is involved, and the services must be documented as delivered. We have a saying with our cases: if it's not documented, it didn't happen, even if it did. And then appeal Medicare denials. So continue to receive care if possible. Ask the home health agency to submit a bill to Medicare for the services if they believe that Medicare will deny. They have to submit a bill if you ask them to. It's also known as a demand bill. And then contact the Center for Medicare Advocacy for assistance with appeals. Okay, so this slide goes against every fiber of our beings to suggest that you compromise care in any way for services that you legally qualified for. But this is our current reality in many places. So to the greatest extent possible, exhaust all the resources we previously discussed. The Center for Medicare Advocacy is working for fair and equal access to Medicare home care. But again, the reality may be that you can only get access to limited Medicare covered home care right now. Let us know, please, through this initiative. Your stories will help to remove unfair barriers to Medicare covered home care. This is what we need in order to prove it has to change. We know your energy and time and ability to fight for what is right is limited, and we need as much help as possible to fix this injustice from all ALS advocates. There are additional resources from the Center for Medicare Advocacy. They're available through our website, and we have we keep trying to come up with information that best helps you to help yourself. So please take a look at those that we have. And I think from now, Matt, we'll go to questions. And I'm sorry, I'm over time.
All good.
Yep, no problem. Thank you very much. I'm sure we could have gone for another hour. We do have a few questions written in. No hands up yet. We'll see how that goes if that happens. But you know what? Let's start big. Let's start with Lynn. If home health care is covered by the law, why is it so often denied, and why does it require a law degree to fight? Asks Lynn.
It's a good a good question, and unfortunate has to be asked. This is Judy. I think the main reasons are twofold. One, as Kathy indicated, home health agencies are currently getting those gold stars you just saw based on measures that count only how people are improving. And we want there to be gold stars given to home health agencies to help people maintain their current function or slow decline and have a good quality of life. And I think that's one of the advocacy efforts that we should engage in together. Those quality measures that agencies need to show that they're doing good work needs to count the good work they do for people who need those services to maintain their condition or slow decline. So one is the quality fit measures, and two, those lead to, in part, to the agencies being utilized and to the payment. And so we need to understand that Medicare home health agencies are not being paid the same for the certain array of services that they provide for people who need them over the long term to maintain their conditions or slow decline. That it's complicated, but in sum, it has to do with the quality measures and the payment. And the payment models are incentives to the home health agency to have people who will come in, for instance, out of a hospital to their care and improve. So, for instance, folks who've had perhaps a hip replacement and are doing well with that hip replacement and need therapy and a little bit of home health aid services for a couple months, and then the services are done. And the payment models currently have incentives for that short-term acute care benefit and don't have incentives for longer-term care that starts particularly happily for people who may not need to have been in the hospital and need that care over the longer term, such as folks with ALS and the other conditions that were represented in the JIMMO suit.
Yeah, and I would add to that it seems like it's getting worse because there have been home health agencies that it's their mission to serve people who are most vulnerable, most in need of care for chronic long-term conditions. And they have found themselves either having to merge with other home health agencies or go out of business because the mission driven statements are not able to be sustained.
Thank you very much. Let's go with one more overarching big picture question, then we'll delve into some of the specifics that people have. Ronnie asks, how can we as advocates ensure that we don't see decreases in benefits in Medicare? What's the likelihood that we'll see reduction in Medicare benefits overall or for ALS specifically?
Well, this is Judy, I'll try that one. You know, I think it's unlikely that the actual law is going to, that Congress is going to pass a law that says, oh, guess what, we've decided not to cover home care anymore, or we're not going to cover outpatient physical therapy. More likely are some of the ratcheting down on payment models that we've just described, or that create incentives for people for home health agencies and other providers to provide care for shorter terms and for more acute care than for people who need care over the long term. Now, look, I've been a Medicare lawyer for over 30 years, and Medicare is an insurance plan. It's a public national insurance plan. It's run by private insurance companies that make claim determinations. And like any insurance, regrettably, it favors folks who are going to get better and do it fairly quickly. That's the way in which we save money for insurance companies, and that's how Medicare saves money, by limiting coverage for folks who need it over the long term. But that's not legal. And the good thing about Medicare, among other things, is that it's a government program. Although it's run, people don't know this, but those claim determinations are made by private entities that work for the government. So I think it's unlikely that we'll see actual limits to what's covered by Medicare. But I do think that more of these management of the care is likely to happen. Prior authorizations, not just the payment models and the quality measures that we've described and are concerned about, but also putting in more requirements for prior authorizations before care is provided, and other benefit management tools that you see in private managed care plans. Those things may come in terms of implementing, and just more denials happening and pressures put on providers.
Thank you very much. Now, I think we're going to head into some more specific questions. First, a clarification on dependent services, I believe. Olga asks, is home health aid also covered continuously, like maintenance therapy, if there's a need or condition? My dad needs help bathing weekly, and the PT from the home health agency said yesterday that would only be approved for 4 weeks while the PT is coming to do her sessions.
This is Judy. There's no duration of time limitation for Medicare home care, nor is there a copay. That's why if it's implemented properly, it can be such a robust, important way for people to stay home. But let me, however, reiterate that there does have to be a doctor's order. Person has to be homebound, which isn't confined to home, and they have to need skilled care. So if that physical therapy is the only skilled service, there's not nursing, or there's not speech language pathology or occupational therapy in place, and the PT is going to stop, and that's appropriate, ask the doctor, then the home health aid won't be continued as a Medicare covered service. However, so long as one of those skilled services is in place, the home health aid also can be in place and covered by Medicare and provide more than just a bath. That's another thing we're hearing a lot. And I noticed you mentioned your father. Did you say your dad was getting a bath? And that's one of the hands-on personal care services that is defined in federal regulation as a home health aid service. Bathing, dressing, feeding. These are services that home health aides can provide and be covered under the law. So again, if the skilled service is in place and the person is homebound, there's no duration of time limitation.
Yeah, let me just add to something that Judy mentioned about there being no deductible and no co-insurance for the home health benefit, which is very true of traditional Medicare. We were just looking the other day at some Medicare Advantage plans, and the majority of them, and again, it depends on where you are and what your plan is, but can have between 30 and 50% co-payments on home health benefits. So you may find it easier to, and again, generalizing, you may be able to get entrance into a home health benefit through a Medicare Advantage plan, but you may end up paying 30 to 50% of a copay on it. So
Thank
just be careful of that.
Yeah, it's important.
Thank you both. We have a raised hand. Let's get adventurous. Let's see if we can hear Jean. Jean, are you there?
Yes, I'm here. This is
Excellent.
from Compassionate Care ALS. I am finding the greatest challenge is just getting an agency in the door. I've heard time and time again, oh, well, we don't have the people, the needs are too great, it's beyond our capacity. And I really feel that it's outright discrimination against this particular diagnosis is what I'm running into. And I don't know, maybe it's because I call up and I say, this is Jean from Compassionate Care ALS. Maybe that's part of the problem. I should just say Compassionate Care, but I don't know what to do about this because I certainly have tried. I understand JIMMO, and I just feel like I'm banging my head against the wall.
Yes, I understand. And we too think that there's discrimination happening, frankly. It could be compassion care, MS, Parkinson's, a lot of folks inappropriately. And, part of me said, well, all of me says, home health agencies get the staff. You're accepting public dollars, Medicare dollars. You're a Medicare certified provider. You're supposed to have the staff under the conditions of participation to provide the care that the Medicare beneficiary community needs. So what to do about it? I think one of the things is we really need to raise this as a public cry. I think that this is a place where congressional representatives and senators need to hear. Indicate and copy us if you do get in touch electronically by email with a congressional representative or senators. I think we need to let CMS, the Medicare agency, know that we're aware that this is happening. It's not just the Center for Medicare Advocacy that is screaming as loud as we can that the home health benefit is being, that the promise is being denied. The coverage is being denied. It's not legal and it's not right. And everybody wants to say that people want to and should be able to be cared for at home. It's like mom and apple pie, right? But if you can't get Medicare and the agencies don't feel they're adequately paid, let's just for long-term care, for care where people don't start from the hospital and they won't come in the door. That's what we're all struggling with, and we I'm not. We feel your pain, and I don't mean that in a silly way. I mean that really seriously. So together, I think we need to raise this as a advocacy alarm, and let Congress people know that because as I said earlier, I don't think Congress would limit this benefit. I think we're going to see Medicare ratchet it down and people encouraged to join those private plans that Kathy just referred to because, we have $1.5 trillion deficit. But I think that people don't know until they're dealing with it how unfair it has become for people who absolutely qualify under the law for these services, and that the home health agencies say they don't have the staff. Well, get the staff. They're supposed to have the staff.
Right. And hi, Jean. It's nice to hear your voice. I think that it behooves all of us. And frankly, because we are so focused on Medicare and everyone else is so focused on doing so many other missions, I think it's really important that we hear from you and any advocates about what you're finding. So because it's collectively these stories together are going to make an impact. It's really hard sometimes for beneficiaries' voices to be heard, and it's really much easier for home health care associations and others to have their space to be heard. But you hit the nail on the head with that comment that it's just really frustrating. But they're going to, and one of the things is they're going to want to hear, did you call all 32 agencies? Did you, what did you tell them that you needed? What is the plan of care? So there's as much kind of legwork as people can do and try to explore all of the advocacy tools. And then we go to CMS and we say, look, we've heard from people in Massachusetts and people in Arizona and people in Florida. And it's not just anecdotal. It's not a one-off. It's not people that are having trouble getting care a little at a time. But unfortunately, this group of folks is not, in the grand scheme of people who are having trouble with knee replacements and hip replacements, it's a smaller number. It doesn't justify that discrimination. But all I'm saying is that we have to fight harder to make it really clear how much of a problem this is.
Yeah, and maybe this is a place where, after our education forum efforts continue together with Team Gleason, maybe we can develop an advocacy action together as well to amplify Steve's wonderful voice and the rest of us on this call and who care so much about this, because people have a need and right to be cared for at home with Medicare coverage when they qualify. And that's why together maybe we can make some change.
Well, and I would add on to that as well, is that I work very hard, obviously, to keep people at home, but then I see spouses of these individuals just absolutely exhausted. Yeah. And they get to a point where they just can't do it. And then what I run into is the nursing homes don't want to handle ALS either. And, we have to make it possible for people to be cared for in their home, because we're really running out of options.
Right.
Thank you.
Thank you.
Thanks.
Thank you, Jean. We have one more hand raised, but Jean just brought up an interesting point that we have a couple questions on, both related to family caregivers being asked to provide services. I wonder, let me see if I can find the specifics.
Well, again, while you're doing that, remember, folks, we have the slides. You have them now, too. At least you can know, someone earlier said, why do you have to have a law degree to make this work? So I have a law degree. Kathy has a law degree. I'm glad for that, but I'm sorry that it does become necessary for you, but you do have the citations now on some of these slides about the fact that they shouldn't be requiring family caregivers to provide care. It should be presumed, in fact, the Home Health Policy Manual says that the caregiver is not available, and what we're wanting is for the nurse, the therapist, and or the home health aides to provide the care. And I know both personally and professionally how hard it can be on family members.
That's great. I think that addresses the issue. The first is I get this answer from my provider. Skilled therapists aren't necessary because I can do it now that I'm trained. I'm not comfortable that what I'm doing is sufficient for my wife's condition. The Medicare contact at my provider says her company is fighting denials like mine that are 2 and 3 years old. And a second related question regarding infusion of particular drug. We experience pressure to have a nurse only come in 3 days and needs to train a family member. We then fight and are denied. We're seeing an increase in infections due to non-healthcare professionals administering.
Yeah, well, I think those kinds, it's outrageous. And if somebody's having, if that's a home health agency or an ALS clinic that's saying they're seeing an increase in infection, and they can perhaps tie it back to this not getting proper care. That's not getting proper care. And, when it gets to the media and someone fails as a consequence, then maybe someone will pay attention, but it's not legal. Kathy, did you have?
Yeah, I was just going to say that we, in our new home health toolkit, we really try to provide the documentation, what's the word I want to use, sorry, to be able to document the need for that maintenance care. So it's Unfortunately, it's easier to document when people are improving. And so that's why you often find these home health agencies that say, oh, well, we'll just train you how to do it and you can do it yourself. And again, the point being, particularly with people who have ALS, it's really hard to know what that limit is if you're doing exercise with them or whatever, if it's range of motion, if it's unless you really are trained and skilled. And that's the whole point of either someone helping you with those exercises or someone overseeing the care in a way that's double checking to make sure someone's not hurting oneself. And so I see that there's two issues. One is that both very legitimate, the caregiver fatigue piece of everything. And the fact that, again, until we can figure out a way to bring attention to it enough to fix it, you know, it's do you call an agency and make that compromise where you accept someone to come in and do bathing, and then you somehow form a care team of volunteers to come in and do some things that are not quite as invasive. I know that's not the answer, and I know if people could do that they certainly would. It's difficult for people to ask for help and accept help, and it's really not their job because Medicare should be covering this. You know, there's this practical reality that I know so many advocates try so hard to work with these agencies to say, let me just get in the door and take what services I can. I will say now with the new conditions of participation, if you get in that door, it also opens up the state survey of safety issues. So regardless of what your plan of care says, if you're not getting the services that you need, there's a state certification licensing issue that pops into play where you can say, I'm being served by an agency, but I'm not getting all the services that I need. Nobody wants to go through all that, but it's a mechanism that is there.
Thank you both. Let's try our last raised hand. Jane, are you there?
Yes. I'm sorry. So I have a client who is a husband. The wife is providing some care 24/7. He is, bedbound. And my concern is that they are giving him limited care. I need to go back to the doctor and get more hours. But how do I deal with the presumption that the wife can provide the care? I want to be able to give her some respite.
Well, it's a presumption that she can't provide the care.
Yeah. The presumption is the opposite, that she can't legally, and it's in the policy manual. We've given you that information on the slide. That she can't provide the care.
Correct, but she's already providing the care some of the time. So,
well, that's all well and good, and it's we all do what we can for one another, but the agency cannot legally limit the care because they think that the wife should be providing more, or maybe she can't continue to provide what she's been providing. People get wrung out, right?
Well, and that in addition to the fact that oftentimes, particularly again under the new conditions of participation, the conversation is to be had at the beginning of care. At what point in time do you have a willing and able caregiver? And it may be that someone says, well, I could be here on Sundays. I want Saturdays to myself. I work 8 to 5. I've got my commute time. And so the caregiver really gets to decide in terms of how much they're willing and able to provide care. And then the home health agency should kind of fill in the difference. And again, in a practical sense, just so you understand, Medicare payments are based on the amount of skilled services that are provided and typically based on the therapy, skilled therapy. So the issue has become, it doesn't matter whether you get 3 hours of a home health aide a week or 30 hours of a home health aide a week. The agency is not going to be paid anymore by Medicare. It's totally unfair and totally needs to be revised in a way that, again, makes care equal and the access equal to everyone.
Yeah, and just another thing I'd say is that it's hard to make this happen in reality, I realize, but people who are physical therapists or nurses or home health aides have gone through training, and they're qualified to do what they do, and the best wife, mother, husband, brother, sister, daughter may simply just is not likely a qualified physical therapist, nurse, or home health aide. It's not the same level of care. It's not the care that the doctor has ordered. And the home health agencies are not meeting their legal requirements when they require that.
Thank you both. I know we are a little over our time limit. We maybe take one more. I have a a homebound clarification question. It might be a nice one to end on.
Yeah.
And then we have plenty, but we will get answers to your questions after the fact if we didn't get to them live. Amy asks, I can't do anything on my own. I require help with absolutely everything. We do have an RV with a special lift that gets me in and out, and we take trips, sometimes for weeks at a time. Does this disqualify me from being considered homebound?
If you, even with the taxing effort, if you leave frequently for long duration, I think it would come down to how long and how often.
Yeah, the only time that I've ever heard something where someone could be away from their home. Now I know there's laws, there is something that may be helpful that says if you have a second home, homebound doesn't mean that you have to just use one home or the other. So you could make an argument that your RV is your second home. The other thing that I was going to mention before that came to mind was the medical cruises. People leave home and they're able to go on medical cruises because and still be considered homebound because there's medical assistance on call, if you will, something like that. So we've heard of that.
Absolutely. So I would think if it's like unfortunately, the law does, we were telling you a lot about what's not happening, and the law allows, and it's fairly open and robust benefit if you're homebound and need of skilled care. But the homebound does mean that you can't leave home for long-term, other than for short duration and infrequently, except for those specific circumstances we said. So if you go on that type of a trip, great, more power to you. But if it's frequent, I think that's probably going to violate the homebound definition. And what's long-term? I mean, if twice a year you go on a week RV with lots of effort, I think we could, hopefully make an argument that your home care shouldn't end when you get back home.
Thank you both. As I noted before that question, we're actually over our time limit for the day. I do want to thank everyone for attending today's webinar. Thanks to Judy and Kathy for a great presentation, full of information. And of course, many thanks to Team Gleason for their support of this initiative. Please do join us May 9th at 3 p.m. for the third webinar in our series that will focus on some case studies. And be on the lookout for info on our virtual town halls that will start in June, so we can take more questions live. One last reminder about those questions we didn't get to that you typed in. We will answer those after the fact and get copies out to folks who attended today. And you can email us for follow-up with your stories and questions, once again, at homehealth@medicareadvocacy.org. Thank you all again. Thanks to everyone that hung out a little bit over time, and I will end the webinar at this time.